Good morning, everybody, and welcome to the European Connected Health Alliance Thematic Innovation Ecosystem on Digital Health and Wellbeing. It's just striking 9 a.m. here in Scotland, in the UK, so welcome to you wherever you are and whichever time zone you are. We have some really great speakers this morning to join us, both from the UK and from Australia and from Wales, so we hope you'll join in the conversation. I'd like to encourage you to please use the chat function to add in any questions while the presenters are speaking. We will have time for discussion, so please feel free to add your questions or your observations or your own reflections. That would be really helpful as well. So if the speakers are talking about something that resonates with you, or that you've had that experience in your region or your local area, or you've had a completely different experience, we'd like to hear about that as well. So I am joined this morning by some great speakers, as I say, who are going to talk to us about where they see the current situation regarding digital health and well-being post-COVID. I want to say post-COVID. I feel a bit nervous saying post-COVID, but as we're moving through this journey, where they see digital health and well-being in terms of whether it is being embedded into, applied, adopted into local and regional and national strategies. And the reason for this session really starts back in May. At the end of May, we had our first digital health and wellbeing session. And at that time, we discussed some of the wonderful examples of digital being scaled up in response to COVID. And we had excellent speakers from Slovenia and also from Scotland. So we were waving a flag for Scotland as well. And we said at the time that really the second part of the conversation needs to be whether some of these changes and scaling up of digital are going to stick. By that, I mean, can we see digital health and well-being being adopted into local and national action plans and strategies? So just briefly to say from a Scottish point of view, we are lucky in many respects regarding digital health and well-being. We have for a long time had a clear strategy around digital health and care. We have very significant challenges around implementation sometimes, not dissimilar to some of the people on the call, but we're seeing a shift in Scotland towards more citizen-focused, person-focused development and delivery around digital health and well-being. But specifically in response to COVID-19, we've had a significant scale up, particularly in services that improve access to health and care. So one of the areas where we have seen development that we can pinpoint and say, yes, this is because of COVID-19, is the introduction of the National Wellbeing Hub for Health and Social Care Staff in Scotland, an online resource, which is now being further developed. We could also see the Connecting Scotland initiative, which is specifically targeting getting people online, again, directly in response to COVID-19, so they can access those services. And we have seen in Scotland the inclusion in a much more direct and clear way in the programme for government, both in 2020 and 2021, just a few weeks ago, the recognition and the promotion of digital to support areas including video conferencing, remote access, remote health monitoring, and mental health. So we have seen some examples, but what we really want to hear about is whether or not this shift is happening more widely, and if we can say that there has been a way that we can pinpoint if this change is going to stick, as I said. So that's enough of an introduction from me. I'm going to hand over to Andy Bleeden, who is the Director of Ecosystems and Membership at the ECHA. And Andy is going to speak briefly, and then we will go to our first speaker and we will take it from there. So once again, please add your questions and your observations to the chat, and we will hopefully have a really interesting session. I'm sure we will. Thanks very much. Andy?
Thanks for that, Nessa. I'll just quickly switch some slides across. So we've got some slides to see. So firstly, thanks for the Scottish Government for hosting this. It's great to see both participation and involvement from our other ecosystems who are here today. Hopefully you can see my screen. Karen's going to nod if she can, because she's the only person I can see.
Yep.
I haven't got my glasses on. Just a little bit about what this is about and why we're doing it. because many of you have been to some of these thematic ecosystems before, so you know. But for those who don't, it's a little bit about us. We are the European Connected Health Alliance. We're a member organisation. Many of you have heard this before. We're growing as a network. That means the good news is that we can bring more good practice, share more share more opportunities amongst our community of around 860 member organisations, about 20,000 people who sign up for our newsletters. And more importantly, with you here today, the 70 plus ecosystems we've got across our network. That network now is represented here today. I had a quick look earlier on by colleagues from Norway, from Finland, from Italy, from Sweden. Hello up there in Sweden, and obviously across the rest of the European ecosystems that are here that I cannot see at the moment, but also importantly to bring on board our colleagues from the Melbourne ecosystem with Karen later, and closer to home with Delith from the Welsh ecosystem, which is fantastic to see. What we tend to do is people join us because they want to promote their organisation and join our ecosystems. That's why you're here today. I won't dwell on that. It's free for most of you to join us if you're a not-for-profit and public body. But ecosystems are becoming more of a common term now. What are they and what do they do? If I can sum it up, as somebody said the other day, it's matching need and solution. It's breaking down silos, it's leading with a need, it's transforming healthcare delivery, but also creating economic growth. Now, we've created a number of these networks, and many of them have joined us in the last 18 months. Our network's doubled in size just about, with the ecosystems you can see joining us on the right-hand side. Earlier on this month, we had our first ever ecosystem from Japan set up, which was fantastic. And that's happened because of our network working collaboratively together. So we've got networks of networks that want to collaborate. That collaboration message has got through to us. So we've now established what we call a network of thematic ecosystems, which aren't based necessarily geographically, but they're run by our ecosystems collaboratively. So for instance, our Australian ecosystem and our Danish ecosystem run one on skills for health. Our Italian ecosystem, alongside partners from Finland, are looking at the area of housing for health. Hello to you, Oscar, because I can see you in the background. But we've also got the Scottish Government who are leading on two important ecosystems, one on integrated care, but also today on digital health and wellbeing. These are about cross-border collaboration. So again, I'm not going to stick around and talk too long because I want to hear what's happening, and as Nessa said, what's sticking. This is where we want your input later when we come to the Q&A sessions, because we're not doing the typical death by presentation today. We're having a look at a couple of examples from both Wales and from Australia of where impact started to drive down on policy, because that's the big so what question with digital health is innovation's great, but if it actually doesn't start to impact and change policy, then it's a waste of innovation, because it's going to have that impact for it to be long term. That's enough from me. I'm going to hand over to our next speaker. I'm going to stop sharing my screen and introduce our next speaker, please. That's it. Have you got the agenda to flash up? Oh, sorry, it's Karen.
Oh.
Karen, over to you.
Do you want me to stop?
No, carry on. Sorry,
No,
Karen, I was flipping between screens at my end. So really just to say, we're handing over to Karen Butler Henderson. Professor Henderson is going to speak to us about the Australian Digital Health Roadmap from strategy to everyday practice and the experience that they've been having over these past 18 months. Professor Henderson is Professor of and Director of Digital Health at RMIT University, which is in Melbourne in Victoria, Australia. So Karen, over to you.
Great, thanks very much, Nessa. So I'd just like to do what we do here in Australia, which is a traditional acknowledgement of our traditional owned land, owners of the land. So I am on Palawa. I'm on Luthawita land, and I acknowledge the Palawa people. So that's a traditional acknowledgement we do here in Australia. So I am talking about what's happened here in Australia, not just in the last 18 months, but certainly how that has shaped what we're doing in digital health. Just acknowledging, a lot of people know where Australia is right the way down the bottom, and it is made up of 8 states and territories. It is actually really large. They say the land mass of Australia is nearly the same size of America. So it's considered a giant island or a very small continent. And in fact, it does also include Tasmania, the big island off the bottom. So whilst I work for RMIT University up here in Melbourne, I actually live in Tasmania, and I live up the north. I don't know if you can see my mouse, but it's up the top here called Launceston. Most maps either forget Tasmania or think that it's another country, but yes, we are a part of Australia, and no, we're not Tanzania. We are actually Tasmania. So it is a big country, but unlike America, it only has, I think, 26 million people. So population-wise, it is much smaller than my country, and much smaller than you know, combined where Andy, Nessa, and Delith are, and a lot of you are. And the reason why is because we have a very large amount of space right here in the middle, which is really uninhabitable. And in fact, the number of sheep greatly outweigh the number of people. The other problem that then causes is that we have vast areas which have no telecommunications and very, very poor satellite. So when we're talking about digital health in terms of telecommunications, it creates really big problems. The other thing as well is, who really wants to go live in the middle of a giant hot rock? So the other problem we have is being able to attract people to come and work in these areas. And so we have very limited number of healthcare professionals. And in fact, I come originally from Western Australia, and I lived and worked up north for a long time. And so what we would find is, you would go in and see a GP, and the GP would say, yes, we need to admit you to hospital. You would walk out one door and in another, and the GP would walk out that door and into another, and then they would admit you into the hospital, because it is all one building essentially. So, you know, when we have a limited amount of health professionals and health services, again, we start having problems about digital health, about the sharing of health information, and there's a number of other complexities that come with that. It is also, just to give you an idea about the land, we have, for example, right here in Western Australia, a place called Kalgoorlie. Driest place actually needs to have water piped from Broome and from Perth to Kalgoorlie. And so as a result, there is a number of social determinants of health playing factors here. So when we talk about digital health in Australia, we're looking at this not just about how technology can support people living in capital cities and focusing on hospitals, but we're looking right the way across, how can we use digital health to be able to support, for example, our large Indigenous or First Nation populations we've got, for example, in the top of Western Australia, quite a lot in Northern Territory, in the top of Queensland. Acknowledging our First Nation populations do live right the way across Australia, but we have very high numbers in these areas. I've just popped some stats so that you could read things on the right instead of having to look at me whilst I'm talking, but it gives you an indication of just some of the health outcomes here we have in Australia. The last thing to mention, as I said, I'm down here in Tasmania. The way that we actually get our telecommunication here is actually through 2 cables that are under the ocean. And this is actually quite a long way. It takes a 11-hour ferry to go from Melbourne across to the north of Tasmania. If those cables get damaged, and they do, you're totally locked out of all telecommunications. And similarly, we only produce power in Tasmania at night, daytime. All of our nighttime electricity comes across that cable. So again, if the cable is damaged, we have no electricity here in Tasmania at nighttime. We're talking about, this is a state of about 600,000 people down here. So that gives you the sort of the scene of Australia. With regards to our healthcare system, we have what's called a 2-tier system. So we have our federal system, and you can see that here in the green colours around this outer ring. And then we have our state system, which is in the grey. And then we have our private system, which is in this dark grey. Now, what this diagram is showing is that we have a lot of our services are actually only paid by one system, either our federal, which goes across Australia, or just the state system. So, for example, the majority of our hospital systems are actually funded under state system or private hospital. Whereas when you have a look at a lot of our primary healthcare services, they're paid by the federal system. And so why this is an important thing is because it means that we have these two separate systems that fund their services very, very differently. And so we end up with very siloed healthcare. So for example, if you're within the hospital system, you're funded, most hospitals in Australia are funded by activity or activity-based services. And then when you leave that and you're then treated in a GP service, or you need to see a dentist or a dietitian, it's then funded under our Medicare system or by, under our Medicare system. And so again, because it's managed by different governments and then it's funded by different mechanisms, quite often we have this gap between our hospitals and our primary healthcare. So we're talking today about wellness. We all know if we have someone who's been in hospital and they're discharged and there's a gap in communication or that continuity of care with the primary healthcare sectors, people fall between those gaps and it becomes a real issue. So we have implemented a number of things here in Australia to try and overcome this federated two-tier system. And just noting that two-tier systems actually built within our constitution, the Australian Constitution. So it's not something we can change very easily. So I've identified today just 4 government agencies that are trying to address this issue and focus on wellness of Australians and focus on these health outcomes and values. We have many other agencies that are related to health and work within the health and care space. But I'm only talking about these 4 today. And this being our main one, the Australian Digital Health Agency, which was previously NETA, the National Health Transactions Authority, I think it stood for, our Department of Health. So again, for all of Australia in our federal, we have one Department of Health, but then every state and territory also has a state or territory Department of Health funded by the state. We have our Independent Hospital Pricing Authority that sets the pricing amounts for our hospitals, but are now looking at how we can extend that across state type services, such as primary healthcare, and then the Australian Commission for Safety and Quality in Healthcare. So, as I said, we've got the Australian Digital Health Agency and they've put in place this roadmap. Now, this is very busy and I don't expect you to be able to see the detail of it, but instead it's to be able to highlight this picture about how they've mapped out the roadmap in Australia for the implementation of digital health technologies that comes from that high Australian government level, driven right the way down to a local organisational level. So when we talk about digital health actually changing policy, we're very fortunate in Australia that even though we do have this two-tier system, that we do have this drive coming from across Australia right the way down across all of our states and into organisations. And I'll give some examples in a moment. The other thing with the Australian Digital Health Agency is they've developed a number of different strategies, and you can see a more extensive list down here. But the 3 that I just want to briefly touch on is, first, we have our Healthcare Identifiers service. And what this is every single Australian citizen or resident is given a healthcare identifier that can be used for any service across Australia. Now, all healthcare providers also have to be registered to this service. And what that allows then is for us to be able to start collating that information together and linking that information across healthcare providers and start reducing that gap. And that's all done through our National My Health Record. So this is a personally controlled electronic health record, and I will come back to that in a moment. The other initiative we also have is the National Children's Digital Health Collaborative, which is to try and put in place from birth this longitudinal record and being able to bring all of the different data points about health and care and social services together to be able to create pictures, the entire picture. And that was only implemented a few years ago. But just going back to the My Health record, this, as I said, is a personally controlled electronic health record. It is not a complete health record. In fact, it's actually a summary of the health summary of the individual. But what it also does is it allows healthcare providers to upload into the My Health record all of the person's testing, whether it's blood tests or radiology, all of their pharmacology, so anything that's been prescribed to them, and all of their vaccines records, allergies, the whole range. And in fact, I've got on the next slide just shows a few more of those areas. But what it does, what that then does is it starts reducing repeat testing and people undergoing unnecessary testing. It also allows being able to monitor tests or prescriptions or etc. over time. It reduces multiple prescription or over-prescribing or inappropriate prescribing, because every single health professional is, when they're registered as a health professional for their individual, is able to access the My Health record. Now, the reason why I made that very clear distinction is because there's a number of security measures in place. We have a lot of legislation around this to be able to protect the privacy of the individual. And we come back to the whole purpose of this is the personally controlled. So this is a person. So say this is me. It means that this person controls who can access their record. And in fact, when someone tries to access the record, you can actually set up your controls so that they can't access it until you give permission. So it is very much controlled by the person, and the person can go in and have a look at any of these types of information that's down here. And I think the one thing that's missing is all that, pathology and radiology is also part of that. And it can be used right the way across. And there's some wonderful videos on YouTube. If you just look on YouTube for My Health Record Australia, you'll be able to see a lot of those examples. Sorry, I'll just move this up here so I can see it. So there's lots more examples on there that you can see. And this here is just to show you an example of what the My Health record looks like. This is my Health record, and it just shows you all of the options. The other thing as well with My Health record is it does allow that coordination of care and the advanced care planning as well. So that we, again, can try and focus on wellness and try and support that person as they do move between healthcare providers as well. The other thing as well that really happened last year was our changing in how we support telehealth services. And this is something that we know happened, globally and across a number of different, across all countries. So prior to COVID-19, we did not fund many services under our Medicare system for telehealth. And as you can see from all these different headlines, the Australian government did implement a number of funding strategies so that we could fund telehealth. But again, it's really focused upon the illness as opposed to wellness. So for example, at the start, there wasn't a lot of funding of mental health services or any sort of wellness or health promotion type services. And then that sort of changed over time. One really great unique thing that happened is within our National Disability Insurance Scheme. So this is our scheme to be able to support people that are living with a disability. And what we found was these individuals prior to COVID-19 had quite often been unable to leave home because of physical or psychological or social reasons. And because of what these service providers put in place to be able to support these people during COVID-19, they started reporting back to us that in fact it actually opened up their social world, Whereas previously, to be able to access, for example, a cooking class, they would have to leave home and go to a facility and partake in a cooking class. Because of COVID-19 and moving those classes online, all of a sudden they're able to participate in a lot more. So whilst the majority of us were really feeling these lockdowns, particularly in Australia and in Melbourne, which I think has got the longest lockdown anywhere in the world, as a result, the people living with disabilities actually opened up their worlds for them. And so again, we're now looking in Australia at how we can change policy long term so we can actually take advantage of some of these benefits. Just wrapping up very quickly it's not just government. As I said, we have state level health departments, which could be a different government to the Australian government, but they all have the same vision, which is being able to use technology to support healthcare. Most states have their strategic vision that's actually driving how they roll out digital health within their states. And then it trickles down again to either a health region, we call them health districts or networks, or organisational type levels. So for example, the Melbourne Biomedical Precincts, it's made up of 4 different hospitals that were able to collaboratively together actually implement technology that went across these hospitals and then the associated health providers. So for example, GPs, dietitians, pharmacy precincts, remote nursing, etc. And so, you know, all these different ones I've got on the screen have different examples of that. And then it does different levels. So for example, here in Tasmania, because we're just one state of 600,000 people, it meant that we were able to be able to roll that out statewide and make sure that we have the same service, whether you're admitted to hospital in Devonport or you see a GP down in, Mona Valley or somewhere, they all are able to access the same sort of information. So just one thing, I just want to wrap up. We have this is published in Australia, which is called The Ingredients of a Well-Functioning System. And I just wanted to leave us on this note with this figure, because to me, when I look at this figure, every single element on it pointed back to digital health. And so to me, the main ingredient for a well-functioning system that puts the person at the center and tries to shift our focus from illness to wellness is to be able to use digital health to be the big giant wooden spoon, mixing all of those ingredients together. Thanks very much.
Thank you. Thanks very much, Karen. Excellent presentation. Lots of food for thought there. Just to remind people to put questions and observations into the chat. I think the highlight of the impact for people who may have a disability was really interesting. So we can see other examples, I'm sure, like that. And I am just going to hand over to Delith James. And Delith works in Wales, as we said at the beginning. And Delith is the programme lead for Digital Health Ecosystem Wales. And she's going to give us a Welsh perspective. Delith.
Thank you, Nessa. Bore da, good morning, everyone from Wales. I'm really pleased to be here with you this morning, and I've been really looking forward to sharing our Welsh perspective with you. What I'm going to do is talk to you about how our Welsh Government is including digital solutions in their strategic plans, what this means in principle for the citizens of Wales, and some examples as well of how we as an ecosystem in Wales are able to support those strategies and help innovation move into service integration. So firstly, though, a bit of background around Wales and how we at the Digital Health Ecosystem Wales are supporting digital innovation in the health and care sector. Wales is a country within the UK, a population of over 3 million, 2 official languages, English and Welsh, and we too have some very rural areas that provide us with those usual challenges around access to services, and we have some urban areas too. The picture on the left is our Senedd. It's the building that houses our Welsh Government, and the Welsh Government is the devolved government for Wales. It's led by our First Minister, and it works across devolved areas that include key areas of public life, such as health, education, and the environment. We have approximately 180,000 people employed in health and social care roles in Wales, and over 98,000 of them working within the Welsh National Health Service. There's a contribution of about 2.4 million to the Welsh economy. The life sciences sector is continuing to diversify and grow in Wales, and it currently employs over 12,000 people from a mix of academic institutions, private clinical research organisations, private life sciences companies, and several specialist support programmes. And this vast range of employers make it a vibrant, diverse and innovative sector that can lead to real and improved change. And due to this variety, the life sciences in Wales are now considered specialists in things like wound healing, regenerative medicine, clinical trials, and e-health, to name but a few. And we feel that this thriving industry has led to it playing a pivotal role in public health emergencies, which was highlighted recently with the coronavirus pandemic. The close relationship between life science businesses and organisations such as the National Health Service in Wales has enabled a rapid response in sourcing supplies to combat shortages of critical equipment, ranging from cleaning products to sort of PPE for frontline workers and caregivers. And this is something that our ecosystem in Wales was incredibly proud to support. Where just in March and June of last year, we reviewed over 200 inquiries of support from that industry sector. But Welsh Government itself, its focus has on digital transformation of health and care services, represents an important commitment and will further put in place significant infrastructure and resource required for Wales to ensure that benefits are captured from this digital revolution. We've learned lessons during the coronavirus pandemic, and we're continuing to learn how we can demonstrate that within Wales health and care systems, and how we can embrace and deploy digital solutions at pace and scale to drive those service delivery improvements. We know we need well-managed and strongly governed access to high-quality, multi-layered data, and we need to attract industry to us to provide opportunities for those partnerships to deliver the required solutions and for the development of new products in Wales. The Welsh Government itself has an ambitious data, digital and technology agenda for Wales. There are digital and data programmes included within each of the Minister's portfolio, and we also have a Chief Digital Officer providing support within Welsh Government, and Welsh Government being responsible for a growing number of digital and data services provided directly to the Welsh public. The digital strategy for Wales states that achieving real digital transformation of public services provides an opportunity to support the ways of working that are described in the Wellbeing of Future Generations Act. Joined up digital public services will be delivered through collaboration and integration. And if you have a look at the graphic at the top right of the screen, these are the Wellbeing goals from the Future Generation Act. And this unique Wellbeing of Future Generation Act means that any private citizen or community group within Wales can now challenge decisions made by public bodies on the grounds that they don't take into account the needs of these future generations. We've got our Informed Health and Care, a digital and care strategy for Wales, and this outlines how we're going to use technology and provide greater access to information to help improve the health and well-being of people in Wales. Within the strategy, it describes a Wales where citizens can have more control of their health and social care, can access their information and interact with services online just as easily as they do with other public sectors or other aspects of their life. It describes a Wales where health and social care professionals have access to the same digital tools in the workplace as they enjoy at home or they would do in other industries, and so that they are able then to focus on delivering safe, high quality, efficient care and plan for workforce and service changes based on those digitally enabled solutions. And An important feature throughout the strategy is that collaboration, that planning and joint working across public services with industry and academia. And that's key in terms of making sure that we in Wales can react quickly to the pace of digital change and identify ways in which best practice can be adopted. It also, though, accepts that although the digital world continues to expand, there are people in Wales who may not wish to access information or engage with services, advice and support, in those ways that are described in the strategy. And we still need to be able to support those people and provide them with alternative options to access services and information. And if you see on the slide on the left-hand side, you'll see I've included a quote taken from the Welsh Government System Reboot report. And I just think that this is so important. And if you just remember one thing from what I've been talking about today, I really hope it's this. It says that digital change isn't just about technology. It's about a change of culture. It's about being open. It's about using data to solve problems. Instead of designing services from the viewpoint of what organisations think the citizen needs, it's about a digital approach involving designing services that meet those needs of the end user. And I think that's just so important. So how do Welsh Government describe that vision for Wales? Well, it's about people being able to look after their own well-being and connect with health and social care more efficiently and effectively. People having online access to information about their own records and being able to undertake a variety of health transactions directly using technology and the use of digital tools and apps. And that's about self-support and being able to monitor people's own health and maintain that independent living as well. It talks about health and social care professionals using digital tools and having that improved access to information to do their jobs more effectively, with improvements in quality, safety and efficiency. And also it talks about improvement and innovation, the health and care social system in Wales being better, making better use of available data and information to improve decision-making plans and service change and drive improvement in quality and performance. These strategies are really ambitious, and what I was really keen to do today as well was highlight just how these have been putting into practice. And I wanted to give you an example of how the ecosystem in Wales is also contributing to this. So in June of last year, our Welsh Government announced the Digital Solutions Fund. It was a £150,000 Welsh Government initiative for rapidly deploying and testing digital solutions to explore alternative ways of supporting needs within our health and social care systems following COVID-19. And we at Digital Health Ecosystem Wales managed this competition and supported the winning project. I'm just going to talk through one of the examples in terms of the bids that we received, as I think this really does demonstrate really effectively how innovation can move into service integration. So MedTrim was one of these successful digital solution fund bids, and to provide support to NHS staff across Wales, the DNA Definitive, which is the organisation with the product, rapidly piloted a digital learning solution for trauma response management. And this really demonstrated how an established programme can be quickly adapted with a digital solution, making it more accessible for those people who need it. We all know that managing well-being is vital for employers across healthcare, never more so than recently with the pandemic. We all see staff of all specialties in demanding and emotionally charged environments, and this does have potentially long-term consequences on both their mental and physical health. MedTrim, it's a medical trauma and resilience management programme that can help support those exposed to those sorts of pressures. And the trauma risk management was originally developed for those working in the military, but was repurposed in 2011 for those working across healthcare. This was a well-established resource for face-to-face learning, and it was about creating an atmosphere where healthcare staff could openly learn to support colleagues following a potentially traumatic experience. However, when the pandemic hit, the programme's face-to-face and classroom delivery was interrupted. And this happened at a time when there was great demand for staff support and training in the face of significant pressure, as you can imagine. Rocketing COVID-19 numbers and unprecedented strain on our healthcare systems, meant that there was no more greater need than this training than ever before. And the pilot aimed to develop a digital learning solution to make the MedTrim course accessible, not only in response to COVID-19, but also looking at the potential of a long-term blended learning approach. The course is open to anyone working across NHS Wales, providing them with access to a digital framework and credible training for managing adverse psychological consequences of potentially traumatic events. Now, there were some challenges along the way. The initial sign-up from NHS staff were low. Informal chats with colleagues revealed this was because staff didn't really have the capacity to enrol on courses like this. Many were working long hours, some dedicated roles had been removed or placed elsewhere, and staff were being deployed to new areas of work. But really, one of the biggest challenges facing participants was being able to get a good internet connection in the workplace, and this was a mixture of lack of good Wi-Fi connections in some buildings, or actually technical issues accessing the course and content online from their equipment, and this limited their ability to access the course. So the project is still ongoing, and we've had over 320 digital learners accessing the course within a few months, and this is almost 4 times the number of delegates who would access that programme face-to-face during the same time period. Widespread of people enrolling onto the course, both in terms of the specialism and the geography across Wales, including nurses, GPs, staff working in intensive care, anaesthetists, and all those that were part of this pilot access the training for free. Some of the feedback we had from a ward sister at one of our university hospitals said, "I just wanted to thank you for the resources that you've provided over the last year for me and the staff. They've enabled me to get through what has undoubtedly been the worst year of my life, and this has enabled me to provide extra support to the staff." And so based on this experience, one of the health boards is embedding this digital MedTrim training for all their theatre staff, and they have 22 theatres in total. And there's also interest in using this programme in training beyond Wales, across the UK, and also internationally. The support from the fund by Welsh Government has created an important legacy in how training and engaging healthcare staff can be achieved rapidly through this digital interface. The pilot enabled DNA Definitive to create the necessary digital methodology and platform for the online training, and then making it more accessible and limited the need to travel. And this helps really contribute to those wider environmental targets that have been listed, as I previously mentioned, in the Wellbeing of Future Generations Act. The course remains available to NHS staff in Wales, and we can now provide that training in 3 different ways for healthcare professionals, depending on their requirements. It could be online, face-to-face, or blended learning. And this feedback in the pilot is now helping to inform future iterations of the training course materials. So that was a bit of a whistle-stop, just in terms of sharing what we've got available to us in Wales. I don't know whether we're going to take questions now, or are we going to move on?
Yeah, no, we're definitely going to take questions now. Thanks very much, Delith. If people want to put on their cameras, I won't force you. I'll put mine on, and you can see it's terrifying, but it's really not that scary. If you want to put your camera on, please do. And I'll just change the view to gallery. So we had some very nice comments and a couple of questions in the chat. So I'm just going to start with those, Andy, if that's okay with you, and then I'll hand over to you.
Fascinating now.
Yeah, really fascinating. So just the first thing to say is thank you. Really, really interesting presentations. As always with these sessions, I think we don't have enough time, but the point is to make the connection. So if there are things you want to know more about, find out more about, the folk who are here and willing to present are very nice, as you can see, and will get in touch with you if you want them to and share their information with you. So I just wanted to pick up on a couple of things. Joanna Dundon made the point about her team are also using a Healthier Wales within Digital Health and Care Wales, which is a later policy to inform healthcare and digital strategy, and talks about using open architecture. And Joanna has very helpfully shared the link. And so if people wanted to check that out, it's got more detail on it. I'm going to shamelessly flag up my own comment because I think it's really important that Delith made the point, and I think Karen also, it was implied throughout your presentation about the importance of that sort of triple helix or even quadruple helix, or depending on how far you want to go. What I mean by that is that the relationship between the life sciences team, health and care, industry, and then we could add in policy, and obviously we should add in citizens and service users as well, but that the relationships there help to actually spur activity and solutions that maybe become more embedded as time goes on, but definitely can demonstrate. So we also had a comment from Sarah. Sorry, Sarah, I'm just scrolling back. If you want to unmute yourself, Sarah, and ask your comment was for Karen, if you want to come in.
Yes, thank you very much for the great presentations. I really enjoyed them. And thank you, Andy, for bringing us together because we learn so much from each other. I also have a question actually to you, Nessa. The Scottish, I was impressed by the Scottish digital citizen delivery plan. And how did you make that happen? So that's one question. And another one to Kerry, I really liked that you put outcomes that matter to the person being very important, but what we struggle with is that mostly actually with the implementation of digital health technologies, that decision makers don't think about outcomes that matter for patients or persons. They more focus on the organization inside. How do you make that happen to really put out the person in the center? Thank you.
Thanks, Sarah. Karen?
Did you want to go first, Nessa, with the first question?
Yeah, I think mine will be probably a bit too long-winded, Sarah, but I will definitely email you. So the Digital Citizen Plan is a result of several years of activity behind that, and it comes out of our technology-enabled care, digital health and care directorate in Scottish Government, but really where it comes from is partnership working for many years with health and social care and third sector or voluntary sector partners, all working together and increasingly recognizing that we can't make sustainable change without digitally enabled citizens. So that's a short answer, but I'm very happy, Sarah, to pick up with you afterwards and put you in contact even with some of the more directly involved authors of the plan, if that would help. I'll share the plan in the links as well, just if others want to know. So over to you, Karen.
Thanks. And I love it how, Sarah, our paths keep on crossing all the time. It's been wonderful. Ours actually started with this conversation. As I said, we do activity-based funding, particularly for our hospital systems. And what happens is we go into these big meetings and the hospitals will bargain or negotiate what they're going to get funding for the next year based upon the activity they did on the last year. And someone pointed out that really it changes this focus on illness, because what then happens is throughout that financial year, we get to a certain point in time and realize that we've been funded to do 4,000 cataract surgeries and we've only done 2,500, and to be able to get that much money next time, they start trying to do deals with general practitioners to be able to get more cataracts referred to them. And, it got pointed out that this was a funding system that just promoted illness all the time. So the Australian Commission for Safety and Quality in Healthcare worked with some other agencies to be able to identify these 21 clinical indicators that if this occurs related to hospital admissions, the hospital would actually be penalised and would not receive the activity for that particular case. And what that started to do was shift it towards the person outcomes. So these were things such as readmission, extended length of stay within an admission, hospital acquired infections, those sorts of things. And what it started to do was shift this focus towards outcomes-based healthcare. To be able to change it as a funding system, as I said, it's locked into our constitution. It's really going to take a lot more, but now we're shifting that right the way across our primary healthcare model as well. The other thing as well was to be able to shift how we use technology to be able to support people. There was this realization that a lot of our technology that we use is developed to be able to support the organization, or at least the clinician, and not actually for the person. So for example, again, electronic health record within a hospital really has been developed to be able to focus on meeting the organization's needs. So it's accounting, or to be able to capture how many incidents had, or etc. It's not actually focused upon, you know, the healthcare that's actually being provided, and particularly patient focused. And so again, it's looking at digital health from that perspective of how can we develop the technology where the primary focus of that technology is about person-centered care, and that the administrative use of that technology is a secondary purpose. Does that make sense, that shift? Great.
That's awesome. Actually, that's the hardest, because technology has been seen as saving money and making, you know, efficiencies in processes within organizations, but not thinking about the people that are getting these services. So thank you, Ray, for that. We can discuss further.
I think there's also a number of resources that we could potentially share by email, might be easier, that have been used to look at measurement and demonstrating impact, and how you actually do that, as Karen said, in a way that doesn't just reflect service efficiencies, which are very important, but actually takes into account the person. So perhaps we can do that as well after the session with those who attended by email. I just want to pick up another couple of points as we go along. So Andy, you had asked in the chat if you'd asked for other examples, and Joffred had replied to say there was an impact on policy, but still thinks we definitely have a way to go to get shifted from pilot projects to have digital health solutions in scale up. And I think actually some of the points Delith made about the wraparound and the policy support really come to play here, where you're trying to shift from policies and from pilots, sorry, into, you know, practical, realized routine services. And Sami had made the point about the changes that are being seen, whether they're sustainable, but digitalization, attitudes, possibilities are growing fast, but we can see that because of the pandemic, we are driving faster with e-health topics. And Mary has asked in the chat, Karen, could you please provide a reference for the paper or the report that you mentioned that was about the ingredients towards the end of your presentation, the ingredients of a well-functioning system. So if you can put that in the chat, if it's publicly accessible, that would be great if you can.
Nessa, will you be sharing our slides? Because I'm happy for my slides to be shared, and it's got the hyperlink on the slide.
Yep, will do. I'm very happy to do that. So Andy, I'm just going to pass over to you if you've seen other questions that I've missed in scrolling, or you have one yourself.
A quick question, if I think there's been some brilliance here, and we've talked before about the crossover between different ecosystems, and we've seen that from Australia to Scotland and back again with the attend anywhere use within Scotland that came from Australia. But I'm interested in those blockers that we've talked about. And I'm interested if people have got practical examples of where legislations had a big kick, because we have seen it. I remember hearing about it in both Greece, in Romania, where someone turned around and said, so it's just the legislation that's blocking us. How can we kick the legislation out of the way, or insert those magic words that say don't as opposed to do? Are there practical examples within the panelists or the participants today of where legislation's been almost accelerated because of the pandemic to make policy changes come in quicker?
If anybody wants to come in on that, Andy, I'm going to repeat part of that just because you're a little bit quiet. So I'm not sure if, don't look so shocked. Your audio is a little bit quiet at my end. So if people have got practical examples, in other words, real world examples of where policy has shifted and digital has been embedded in for health and wellbeing services, I wonder if, I gave some examples from Scotland, but I wonder if the policy, the feed up to policy change has to be evidenced in action plans and local delivery plans first, or whether it's happening more quickly than that now, or if it's happening from both directions, if you see what I mean, policy and local action plans. So if anybody would like to come in, please. You've all gone quiet.
You can raise your hand if you're worried about how to do that at the bottom. If you hear that, there's a little reactions thing at the bottom, like this.
Okay, so that either means you don't think that's the case, or you're all just too shy to say anything. No, I'm going to come back to you, Delith. Delith, you talked a little bit about the change that you've seen in Wales. Do you think, I suppose this is a difficult question and apologies in advance, Delith, do you think the change is going to be sustained? Is that your sense at the moment, or do you feel it's still a bit too early to tell?
Oh, that is a good question. I think it's probably just a little bit too early to tell yet, because I think there is that enthusiasm and the attitude towards it, but it's whether or not that becomes sustainable. You know, we have projects, we have pilots, and there is that opportunity to roll out further. But how do we ensure that that becomes sustainable and that becomes part of that policy? So I'm not sure whether it's. I think probably we are a little too early to be able to see that in action.
Thank you. Thanks, Delith. And just before I go back to Karen with the same question, Alan, thanks, Alan. Alan has made a point in the chat which relates to that, really, Delith, in saying that the policy can shift, but if we still have the issues, I'm interpreting slightly, Alan, if we still have the issues raised by our presenters about connectivity, in particular, difficulties with connectivity, and a lack of health and care professionals. So in other words, scarcity of resources, they also need to be addressed in parallel to make that shift real. I think that's where you're going with that, Alan. You feel free to come in if I've misinterpreted. No?
No,
happy?
hitting it on the head there, Nessa.
Okay, thanks, Alan. So Karen, I would just come back to you with the same point, really. It's about, do you see the shift being sustained in where you are, and do you see the shift being sustained in terms of, you know, wider feed into action plans and policies?
So I do see it as being sustained here in Australia because of how I presented about that top-down approach that we have, where we've implemented as a countrywide strategy from our Australian Digital Health Agency, and then that feeds down into our state level strategy and then those organisational strategies. Telehealth, what COVID-19 did was accelerated the strategy. So there was a number of things that might have been much further down the track that had to be rolled out a lot sooner because of COVID. But also there was things that when it was first rolled out, it was felt it wasn't going to be sustained. So for example, the telehealth funding, and then because it's like, you know, you give a kid a lollipop once, next time you go to the shop, do you really think they're going to accept you saying no, they can't have another lollipop? You know, they gave us a taste of what this was like, and now we want to keep this. And I think that it will be very challenging to be able to go backwards on certain things and not do it. However, the other point that I also just want to share is, quite often when we see these things being rolled out, they get very distracted by the shiny thing being the technology, and what does get forgotten is all the other things that come along with the technology and needs to be planned and considered and etc. And so, as Angie said at the start, so as part of the Melbourne ecosystem, along with Denmark, do the Skills for Health thematic ecosystem, and we know workforce is the #1 area that is quite often forgotten about when we start looking at how we're going to change and shift and move forward with digital health, and particularly around those capability areas.
Thank you, Karen. And I'm just going to wrap up, Andy, if that's all right. And I will hand over to you just to say, we asked you previously about other topics you wanted to hear from this ecosystem. So topics related to digital health and well-being. This is just our second session. We will ask you again by email just to pin them down and pin down dates for next sessions. But really many, many thanks to speak. Oh, I have a hand up. We're nearly there. Sorry, Rudita, I didn't see it. On you go.
Hi, hello. I just wanted to thank you, everyone, for this opportunity to join those great presentations and experience sharing. I am from Latvia. It's one Baltic state, small country in the Europe, and currently we are in the process of designing national digital health strategy, and as well attempt to rebuild, to get next level with our digital health IT ecosystems and e-health solutions. It was great to hear both from UK experience, Scottish and Australia. I love those countries very much, and I've been traveling both once in Australia and several times in UK. It's really great that we have so close opportunity to talk and discuss all over the world, actually. And it's amazing what technology can enable us to do. And we are in learning process, and I'm very excited to participate at this national developments and be a part of this digital health agenda. And I feel real like world citizen now in this. Thank you very much for your time and experience. Then I will be following also next opportunities to join and talk. Thank you.
Thank you, Rudita. Lovely comments. Thank you very much. Andy?
Yep, brilliant. Thanks for that, Rudita. I will come back to you directly because we don't have an ecosystem in our network from Latvia yet. I'll be in touch. So
yeah.
My email's at the bottom. We'll be in touch. This is about growing our connections and our contacts and our collaboration. I think today has been a fantastic showcase for 3 countries here with 3 different systems with input from ecosystems from around the globe. Thank you to all those people who've taken part. Thank you, Nessa, for organising this and staying focused on this. And also thanks for both Karen and Delith for your contributions and your time today. I think that's done exactly what we said we were going to do, which is to say, where's the policy impact? So thank you very much. We will come back to you, okay, with a next ecosystem meeting date and topic. Stay tuned. Thank you very much.
Thanks, everyone. Bye-bye.
Thank you. Bye.
Thanks, Karen. Thanks, Delith. Thank you, Nessa. Good to take. We'll be in touch.
Yeah.